Hi, uh, I'm Peripheral. I'm the endovascular fellow at Mount Sinai Medical Center. So today, with relevant to what we did in our case, I'm going to talk about two topics. The first one is going to be about management of common femoral arterial disease, and the second one will be about the use of drug-coated balloons in long femoropopliteal lesions. So the first topic on common femoral arterial disease. This has often been treated as a no-fly zone. The reason being, if you put a stent in, there's a high risk of stent fracture. There's increased risk of intimal hyperplasia and restenosis. And also, there's a concerning risk for jeopardizing the collaterals. There's a risk of injury to the profunda depending on its proximity to the CFA lesion. It's considered a surgical bypass landing zone. And the common femoral artery is prone to several forces like flexion, extension, and torsion. And it has always been taught to us that surgery is the gold standard. So we're going to review some of the retrospective studies and other data and see whether the following statements we made is true or not. So this is a series published by Dr. Cambrier from Mass General Hospital. Essentially, they were looking into common femoral artery occlusive disease to see how surgical end arterectomy did. So, with the recent advances in the endovascular therapies, there was a question as to whether surgical therapy stood its place and whether it was still considered the preferred therapy. So this was a single center retrospective review from Mass General Hospital. 65 common femoral end arterectomies were performed on 58 patients between 2002 and 2005. 57% of the procedures were hybrid procedures, meaning they got open access into the common femoral artery, and then if there was an iliac lesion, they deployed a retrograde sheath, fixed the lesion, and in case there was a SFA lesion, then they deployed an antegrade sheath and fixed the lesion. And after that, they performed the end arterectomy. So patients were excluded from these series who had previous CFEs, previous CFA bypass grafts, endovascular AAA repair with CFE, and remote SFA end arterectomy. The mean follow-up on these patients were for 27 months. So some of the definitions we need to understand in this study was patency was referred to the status of the common femoral end arterectomy, irrespective of what the status was of the distal revascularization in red. Then primary patency was defined as a patency of the CFA without evidence of restenosis or need for reintervention. Primary assisted patency was defined as a patent CFA that needed at least one reintervention for recurrent stenosis. And finally, freedom from reintervention was essentially anything involving the ipsilateral limb. So these were some of the baseline demographic and clinical features. Now, as you can see, that there is a significant proportion of patients with CHF, COPD, and also chronic renal insufficiency. Therefore, this is simulating very much the real-world patients we commonly see. And as you remember, most of these randomized controlled trials tend to exclude patients with severe renal disease, especially those in dialysis. So the clinical presentation of these patients involved an entire spectrum from moderate claudication to minor tissue loss. And the lesions involving the concomitant iliac and the femoropopliteal segments ranged from A to D. So at the end of 5 years, the primary patency was 91%, and at 1 year was 93%. The primary assisted patencies at 1 and 5 years were very impressive at 100%. Therefore, these results were very encouraging, showing that surgery has stood the test of time. They had 100% technical success, which is defined as less than 20% angiographic residual stenosis. They had a 95% hemodynamic success with an improvement in the ABI greater than or equal to 0.1, or plethysmography tracing increased by greater than or equal to 5 millimeters. They had a 99% clinical improvement. No patient's condition was made worse. Now it's interesting to note that 42% of them had under general anesthesia, 47% under epidural anesthesia, and 11% under local anesthesia and sedation. I think this breakdown is important because this tells you that in very high-risk patients with the appropriate expertise and in the presence of an experienced operator, these procedures can be performed under local anesthesia. Now, congestive heart failure was considered the only multivariate predictor of primary failure and reintervention. Interestingly, there was no differences in the primary patency rates or reintervention when you compare claudicants with CLI, diabetics with non-diabetics, isolated CFEs with hybrid procedures, untreated SFA without untreated SFA. So they had 13.8% rate of complications, with 5% being major. One of them had lost the distal flow because there was untreated external iliac artery stenosis. One of them had an expanding hematoma which needed surgical exploration. And one of them had an infected pseudoaneurysm which also needed surgical exploration. So these were some of the reasons for the primary failures at different time zones. And as you can notice that there is a distribution from common femoral artery restenosis to involvement of other vessels, proximal and distal to the CFA. So the freedom from reintervention from the ipsilateral rim at 1 year was 82% and at 5 years was 78%. Once again, very encouraging results. Survival at 1 year was 89% and at 5 years was 70%. So echoing this study were several other smaller similar CFE studies which showed similar results with Mukherjee's and team having a 5-year patency rate of 94%, Spring-On and team having a 5-year patency of 74%, Nelson and team having a patency rate of 84%, Kechigias and team having a 68% freedom from any ipsilateral revascularization at 5 years. And they had a patient number of close to 100, and the rest of them were approximately in the 30 range. So now comes some data regarding the endovascular treatment of CFA disease. So this paper, which was published in JACC by Dr. Zeller and team, essentially what they wanted to do was to evaluate the technical feasibility, safety, and 1-year efficacy of endovascular treatment of atherosclerotic common femoral artery obstructions. This was a retrospective study of a prospectively maintained single database in Germany. So the aims, the feasibility was basically the number of successful procedures divided by the number of attempts. Technical success rate was considered if you had an angiographic residual stenosis less than or equal to 30%. Safety was essentially in-hospital major and minor complications. And then the medium-term outcomes, which is essentially all the way up to 1 year. So this is a busy slide with fine print, but essentially what they did was they screened all the patients who had underwent intervention from 1996 to 2007. They identified 516 patients. They excluded patients who had vascular closure device injuries, bleeding, thromboembolic lesions, stenosis which was not considered significant, iatrogenic dissections, and a couple of other causes. Finally, in their pool, they had approximately 350 patients to analyze. So these were some of the baseline characteristics. As you can see, once again, representing some of the real-world patients we see, with a proportion of patients having chronic kidney disease, coronary artery disease, and lung disease. And also the clinical presentation from a Fontaine classification perspective ranged from claudication to early CLI patients. They also used a classification which is similar to the Medina classification used for coronary bifurcation disease. So essentially, they wanted to see if the profunda artery was involved, and therefore emphasizing that when we perform such endovascular treatment, it is important to identify whether the profunda artery is involved in the lesion and also its proximity to the CFA lesion which we are treating. So these were some of the lesion characteristics, procedural details, and equipment. So here you notice that 37% of the patient required stenting because the operator felt the dissection or whatever it was of concern needed so. A good number of patients had chronic total occlusions, and then as you can see with the Medina classification, a good number of patients had involvement of all the three segments, that is the common femoral artery in proximity to the profunda and the SFA chest at its origin. And also a significant proportion of patients had a significantly associated profunda arterial lesion. So I think it's important to identify these features because this tells you that the substrate of patients that we're dealing with, both clinically as well as from an anatomical perspective, were high-risk patients. So their outcomes, as well as from a procedural and clinical perspective. So they had an excellent procedural success rate of 92%. I will come down to the complications on the next slide. Their target lesion revascularization was 20%. And then when you look at the amputation rates, they were pretty minimal. So the procedure-related complication was totally 6.4%, which 1.4% required surgery, and the other 5% was treated percutaneously or conservatively. So therefore, very impressive results, and definitely when you compare it to surgery, where they had close to 5.8 significant complications, and also some studies have reported as high as 22%. So when you look at this multivariate analysis of clinical and procedural predictors of adverse events for CFA interventions, you notice that patients who've had infrainguinal intervention, in addition to CFA intervention, obviously the TLR rate is high. If they have bifurcation disease, the TLR rate is high, so is the restenosis rate, so is the procedure failure rate, and again, depending on the Medina classification, your TLR rate and your restenosis rate does go up. Now, when they use the stent, as you can see from this table, that the TLR rate was reduced, and then also depending on whether you had a chronic total occlusion and diabetes mellitus, these influence your peri-procedural complications. And also interesting to note was that when you look at the procedures performed before and after 2001, essentially reflecting on the advancements and the improvements made in the endovascular technology, this was reflected on the procedural failure. And this was a study which was published in 2011, and we know that from 2011 to now we've had further advancements, especially the introduction of drug-coated balloon into the United States. So I'm sure that these numbers will look much better if performed today. These were some of the multivariate analysis performed on 4 different patient subgroups, which is isolated CFA, de novo lesions, stented segments, and then finally atherectomy. And these were compared with their counterpart group. And as you can see here, that the patients who are stented tend to perform a little bit better than the non-stented group. And then when you compare atherectomy with PTA and stenting, even though the number of patients in the atherectomy group was not a lot because they just started to perform this, there wasn't any significant differences in the results. And then when you compare de novo lesions with the post-TEA, there wasn't any significant difference. And similar with the isolated CFA and CFA with other vessel PTA. So the most important or significant difference was in the stented versus the non-stented group in this table. So this is the Kaplan-Meier survival curve, which looks at restenosis-free proportion extending all the way to 100 to 120 months. Similarly with the target vessel revascularization. So therefore, this study essentially said that endovascular treatment for common femoral arterial disease was a very strong alternative option to surgery. And also, what was very impressive was the low complication rate, and also the fact that the use of stents in the common femoral artery seemed to yield very good results all the way to 1 year. It will be interesting to see what the real long-term data on this, and also to see what is the real incidence of stent fracture. So this was the same group which essentially used the same data and published it in another journal. This was another retrospective review from United Kingdom, which was published recently. It essentially looked at patients with limb ischemia involving claudicants and critical limb ischemia. They had a 90% technical success rate. Their complication rate was very similar to what the Dr. Zeller's group saw with around 6%. Their 30-day mortality and amputation rates were 2.5 and 0.8%. And they had encouraging limb salvage rates, survival free from reintervention, and survival free from amputation at 1 and 3 years. Therefore, this study pretty much echoed what Dr. Zeller's group demonstrated, showing that endovascular treatment for common femoral artery disease is an excellent alternative to surgery, and the low complication rate is definitely very, very encouraging. So with this, I would like to talk about the TCORE trial. Now, this is actually the first randomized study which compared endovascular versus open repair for common femoral artery. This was a multi-center trial in France. It involved 120 patients. Essentially, they looked at morbid mortality rate at 30 days, which was defined by death, general complications, local complications requiring readmission and or reoperation. So this study was presented at the LINC meeting last year. It is not published, and I think in the next year or two we would definitely see some papers. So their intent was essentially to see how these two therapies did when compared 1-to-1. They found that open surgery definitely was an effective and durable procedure. There's no doubt about it. But what was concerning was the perioperative complications, which they code as high as 22%. Endovascular repair, on the other hand, showed that they had a promising morbidity and mortality rates of 5%, with encouraging sustained clinical improvement at 1 year. And finally, the stent fracture rate was really not as bad as people thought. It was at 2.5%. So after this pilot trial, they were encouraged to go ahead and perform this multi-center trial. So this was done across several sites across France. The main inclusion criteria was any patient in the age group 40 to 90 years old, de novo erythrometas, common femoral artery lesions involved in Rutherford stages 3 to 6. Main exclusion criteria was restenosis, thrombosis, absence of atherosclerosis, asymptomatic lesion, and life expectancy less than 1 year. So the procedures performed was open repair, which is performed at the discretion of the physician, and the endovascular repair, which involved primary stenting and the other basic approaches. The primary endpoint, as I mentioned earlier, was morbid mortality rate at 1 month. But they also planned to look at the data following 1 to 2 years. They divided the analysis into intention to treat and per protocol. So intention to treat is what you initially classify or randomize these patients to, and you will analyze them based on what you did right at the beginning. Whether you put them into group A or group B, you stick to that. Irrespective of whether a group A patient finally got treated with group B middle of the trial, doesn't matter. You treat them or you analyze them the way they were randomized initially. Per protocol analysis, on the other hand, is analyzing these patients based on what treatment they received. So for a statistician, the appropriate way to do is intention to treat analysis. And for a purist or interventionist, if you really want to see what your device did, then a per protocol analysis would be a fair thing to look at. They had a sample size of 120 patients, and these were some of the baseline demographic data. So they were very well matched with equal proportion of claudicants in the open repair and endovascular repair. And OR stands for open repair and ER is endovascular repair. These are some of the intraoperative data. It's important to note that in the open repair, 80% of them had general anesthesia, unlike the contemporary series published by Dr. Cambria, where approximately 50% of them only had general anesthesia. And then finally, the endovascular repair, these were the numbers with regards to local anesthesia, the approach, the closure device use, concomitant endovascular treatment, and technical failure. So this was the flow chart. The 61 who were assigned to surgery were the intention to treat, 59 assigned to endovascular with was also under the intention to treat, and finally per protocol was 60, and then 54 under endovascular. So they further subdivided their lesions into type 1 and 2 and 3. Type 1 essentially involves a common femoral artery extending into the suprainguinal region, and type 2 involving just the common femoral artery below the inguinal ligament. Type 3 involves the common femoral artery, SFA, and the profound artery. They also had a type 4 which involved the graft. And as you can see, the distribution between the two groups was pretty similar. Therefore, they tried to keep it as fair and square as possible. So these were the results at 1 month. The intention to treat analysis was not significant, but had a trend of P of 0.08. And if you look at the numbers, it was 26% in the open repair, and endovascular at 14%. Now, when you look at the per protocol analysis, the open repair at 23% and the endovascular repair at 6%, far lower. And if you notice, p-value was significant. So therefore, when you looked at per protocol analysis, endovascular repair achieved its primary endpoint and thus had a lower morbid mortality rate at 1 month. Now, looking at the secondary endpoints, the hospitalization length of stay was significantly lower in patients who underwent endovascular repair. There was no differences with regards to thrombosis or target lesion revascularization at 1 month. And again, there was no differences between the open and endovascular repair at baseline and at 1 month with regards to the hemodynamic outcomes, which was essentially the ABIs. So in conclusion, at 1 month in per protocol analysis, endovascular repair with primary stenting of the common femoral artery, atherosclerotic lesions yielded a significantly lower morbid mortality rate when compared to the open repair, with similar clinical, hemodynamic, and morphological outcomes. And definitely it'll be very interesting, and I'm definitely eager to see what the 1 and 2 year results would be, especially the fact that we've always treated the CFA as a no-stent zone. So with this background, Dr. Zeller and group published this algorithm in one of the journals, and I think I find this pretty useful, especially for beginners, to kind of help them to negotiate through their endovascular management or surgical management when they see a patient with CFA disease. So once you identify a CFA lesion, you determine how calcified it is. If it is severely calcified, then it seems pretty appropriate to perform surgical endarterectomy. On the other hand, if it's no calcification, or there's mild to moderate, then endovascular approach can be considered. Also, patients who are high surgical risk, and as you remember from Dr. Cambria's contemporary series, congestive cardiac failure was one of the, actually was the only multivariate predictor for primary failure and for reintervention. So therefore, I think certain kinds of high-risk cardiac patients would do definitely better with endovascular approach. So once you determine that this patient can be considered for an endovascular approach, then you have to determine what kind of lesion it is. Is it a bifurcation lesion? Then you further classify it based on the Medina classification. Is it de novo atherosclerosis? Is this restenosis? And then depending on what kind of bifurcation lesion, you can go ahead and perform with 2 wires, kissing balloon technique, and stent if needed to. And they suggest that if you have to stent, to consider the 1 stent technique. And if it's a de novo lesion, just consider plain balloon angioplasty. But I think it'll be interesting to see how the drug-coated balloon performs. Now, if it's restenosis, to consider atherectomy and a DEB. Again, if none of these succeed, it's important to consider surgery at all stages. So with this, I want to end my talk on management of CFA lesions, and therefore, with what data we have, I think our treatment should be tailor-made for our patients. So if you have a young patient who's got decent amount of calcification, does not have a whole lot of comorbidity conditions, and if you have an excellent surgical experience at your center, then you should definitely consider endarterectomy, just because it gives you such durable results. Because remember, you want to cut down the complications associated with surgery. On the other hand, if you have a patient who is high risk with a lot of cardiovascular comorbidities and the lesion looks reasonably favorable, then endovascular treatment should be considered. With that, I want to talk just a few slides regarding the use of drug-coated balloons in long femoropopliteal lesions. When I was doing the literature search, there wasn't much data really looking into this, and especially with the fact that drug-coated balloons just have been recently approved in the United States. It will be a little while before we get some more hardcore data. So this was one of the excellent studies I found, which compared drug-coated balloons and drug-eluting stents for treatment of long femoropopliteal lesions. So this was a retrospective dual center study done in Germany. 131 DCB patients were compared with 97 DES patients after propensity score stratification. So propensity score stratification is done when you're kind of trying to simulate a randomized study in a retrospective analysis. Essentially, you match these patients, find the confounding variables, and then finally try to find those patients who match without these confounding variables. So therefore, you're trying to perform a crude randomization. Now, long femoropopliteal lesions in this study was defined as lesion length greater than or equal to 10 centimeters. Patency, clinically driven TLR, event-free survival, and freedom from worsening, Rutherford classification by greater than or equal to 2 stages were some of the endpoints they were looking at. The patency was essentially determined by duplex ultrasonography with a peak systolic velocity ratio of less than 2.4. So these were some of the baseline characteristics. Because of the propensity score matching, you can see that the various clinical features as well as the Rutherford class was reasonably matched. Some of the lesion characteristics, most of them were matched except for the fact that the DCB group had all the mid-popliteal lesions. Obviously, the DES group did not have it because we've learned that stenting in the popliteal artery is not a good idea. Therefore, there is number is 0. And then when you look all the way down, especially subintimal, obviously stents were used more often if we felt that we were subintimal throughout a CTO. Now, they did not find any difference between the DCB and the DES with regards to freedom from target lesion revascularization, the light line being the DCB and the dark line being the DES when they looked all the way through 12 months. Similarly, no differences when they looked at event-free survival all the way to 12 months. Now this, I find it as an interesting slide because the red line depicts essentially drug-coated balloon with provisional stenting. So essentially what they did was, after they performed the drug-coated balloon, if the operator felt the patient needed some kind of focal stenting, then they chose a bare nitinol self-expanding stent. And what they found here was there was a trend that patients who had provisional stenting following DEB or DCB had a better freedom from target lesion revascularization. But this was not statistically significant, but definitely something thought-provoking. And similarly with event-free survival. So when they looked at the ABI in the target limb at follow-up, they had no differences except at 30 days DES had a better ABI result. And I think one of the reasons is probably because there is the concept of recall, which the stent is able to overcome, but the DCB is unable to. But since the drug acts predominantly the first 30 to 45 days, it performs the function, and then it overcomes the deficit of recall, and therefore prevent restenosis, and therefore you don't see much difference when they looked all the way to 12 months. And with regards to major adverse events at 1 year, there was no differences between the two groups. So therefore, I think what this retrospective analysis highlights is essentially the 1 year outcome of DCB and DES angioplasty in long femoropopliteal lesion compares well with the currently published outcomes for bypass surgery for these TAS C and D lesions. So definitely some of our patients who do present with TAS C and D lesions, DCBs can definitely be considered. And the other important point, or something which should be borne in our mind, is the concept of DCB angioplasty with provisional stenting seem to have a slight edge over DES implantation. So with this, I want to conclude on these two topics. Thank you.